My understanding is that our payroll taxes, our Medicare and Social Security taxes, are the largest tax that about 85% of American families pay. And yet every time I read a report from you, or read those reports, and they hadn't gotten any better, is that there's not enough money coming in to do the things that we've promised to do. I can't believe that I read your testimony correctly, but I want to check it out with you. $32 trillion over 10 years as the best case scenario, not for the total cost of Medicare for all, but just the add-on to the current Medicare program that is already there. Am I reading that correctly?
Yes, that's a lower bound estimate of the additional federal obligations above and beyond current federal health obligations. I sit on the Budget Committee, and we're not able to pass a budget out of the Budget Committee because we couldn't even agree as a committee on how to sort out our current challenges, much less future challenges. But it was going to be about a $4.5 trillion budget, a little under that. Best case scenario, $3.2 trillion annualized over 10 years. Worst, but more appropriate scenario is your nearly $40 trillion number the worst case scenario or an expected scenario? I wouldn't say it's a worst case scenario. I think basically the cost estimate over 10 years would be in the region of $40 trillion if you didn't assume any particular targeted savings from Medicare for All. Of the different categories of potential savings from Medicare for All, I think the relatively most likely is probably administrative cost savings, which would bring the total down to about $38.8 trillion over 10 years. But depending on your assumptions for provider payment rates, drug costs, things like that, the additional federal costs would be somewhere between 32.6 and 38.8 trillion.
Help me with that math. Looking at your best case scenario, your lower bound, everything goes right. What are we talking about in a per American cost, per person cost?
Well, this is very crude, but it's about $10,000 per capita, per person, additional federal cost.
So 320 million Americans, okay.
Exactly. I mean, 35 trillion, 350 million Americans, okay. It's about 10,000 per person. That's
real money. And I was listening to your testimony, Dr. Collins, and as you were going through some of those numbers and talking about after the Affordable Care Act, things that had gotten better. And I want to stipulate that I agree with everything that you said about increased outcomes. What wasn't reflected there, though, is whether we got the best bang for our dollar. Of course, if I spend $1 trillion new on health care, subsidizing American families with their health care costs, when I run a poll that says, are your health care costs easier to manage today than they were yesterday, folks are going to say yes. I don't think that's the right question, though. I think the question is, we agreed to spend $1 trillion. Are we spending that $1 trillion in the way that helps the most families do the most work, do the most for themselves, reduce those stresses that we've talked about? Have you seen any data along those lines? Not did we do better, but did we do the best we could do given the enormous resources we invested?
We can actually do better. 17 states haven't expanded Medicaid, so that's one area where we haven't fully implemented the law. There have been some changes to the cost sharing reduction subsidies in the marketplaces that have bumped up premiums on silver plans, which has hurt some people, but people's tax credits adjust, and actually the federal government's paying a lot more because we're not paying these cost sharing reduction subsidies. So in terms of implementation, there are definitely areas where we could do better. We could extend the subsidies so that people just over that threshold for marketplace tax credits could afford their plans. But I also want to say too, on the Affordable Care Act didn't really.
Let me reclaim my time just for a second, because I understand that if we wanted to improve the Affordable Care Act in its current structure, there are lots of things that folks would do. In fact, I suspect there are lots of men and women around this table who would rather do that than the Medicare for All plan. That wasn't the question I was asking, though. My question is, and it goes a little bit to what Dr. Nabi said. He said 41% of folks reported they didn't go to the ER even though they thought they needed to go to the ER. Every ER physician I talk to says, Rob, we're in a conscious effort to keep people out of the ER. People keep wanting to come to the ER. We don't want them to come to the ER. We want them to go to our urgent care center right next door, because when they come to see us, if they don't really need to see us, we're wasting valuable resources on them in our environment because it's hyper expensive. We could have served more people in more ways if we could have redirected them. And that's what I'm thinking about, maximizing the dollar that we're spending, let's agree we're going to spend more money, but let's demand the very best of that money. And I think about that in your case, Dr. Navi. How does the Medicare for All plan, as Ms. Jayapal has crafted, what incentive is there then to do what all ER physicians are telling me needs to be done? We got to keep folks out of the ER, get them into urgent care instead. What is the skin in the game that keeps me out of your office? And
it doesn't need to be skin in the game. People want to go to their primary care doctor. They don't want to see me, and frankly, I don't want to see them. I agree with the doctors you talk to. When a patient comes to me and they want me to adjust their diabetes medication because I'm the only doctor they could see, because they're the only doctor they could access because I'm in the ER, I feel totally comfortable intubating someone, doing chest compressions, treating a heart attack or a stroke or stabbing or gunshot. I don't feel comfortable adjusting someone's diabetes or high blood pressure medication. That's a primary care doctor's job.
Your experience is that overutilization in the ER doesn't come from my misunderstanding as a consumer of what my needs are. It comes from EMTALA requires you to see me, and that's why I show up on your doorstep?
Yeah, patients often come in and they'll come to the ER. They say, I took my blood pressure at a pharmacy. I went to the Rite Aid, and they had the machine there for free. It was through the roof, so I didn't know what to do, so I come to the ER. I don't want them there. I want them to go to their primary care doctor. It'll be cheaper for them. It'll be better for them. It'll be cheaper for all of us. It'll be better for me. That's a win-win. I don't need to incentivize them. They already want to go there. They just can't get in.
That is a win-win. I think about that, Ms. Turner, and some of your testimony about your desire to do better. You've invested a lifetime in trying to move us in a better policy direction. I was visiting with a small-town doc in Georgia. We did not expand Medicaid in Georgia. And he said, Rob, you hand out all the new Medicaid cards you want to if it'll make you feel better. But I'm the only doc in 5 counties who still sees Medicaid patients, and I can't fit anybody else in my waiting room. So we're not going to achieve Dr. Navi's goal of providing more care. We'll just achieve a policy goal of feeling better about what we're doing in rural Georgia as it sits today. What policy reason is there? If I want to achieve Dr. Navi's goal of not seeing folks walk out the door because they can't pay for their care, I don't understand the policy reason to take away all of the DOD healthcare system that my men and women in uniform tell me that they love. I don't understand why we have to abolish every union healthcare system that my union members back home say, Rob, I've got the best healthcare on the planet. Why, to achieve the goal of serving the underserved, is the policy solution to take everything away from people who already feel well served?
And I think that's really a crucial issue. What do we need to do to fix the current system rather than blowing it up? Because there are a lot of systems in the employer community, in TRICARE, in Medicare, to try to provide this kind of coordinated care, to provide better access for people, more humane, better coordinated care. If Medicare fee-for-service is used as the model, all that's blown up. And can we create a new system for better coordinated care in 2 years? Extraordinarily difficult. I think we have to value what we have, build on that, and solve the problems that we have, but not destroy what's worked and what we've built over decades.
Well, even in the Medicare system, in my jurisdiction, I live in a suburban area, and so we have lots of providers. But more than 40% of my seniors have opted for Medicare Advantage. They've said, I don't want the traditional Medicare system. I have a better option. Now that you've provided that option, I'm going to choose that. And, of course, that goes away, too. We poison the well of productivity around here on a regular basis. And I want to thank each one of you in your testimony. No one went out of their way to poison the well. And, again, you were chosen for a reason to get this conversation started. I think we can achieve Dr. Navi's goal of not having the underserved walk out on what ought to be an affordable procedure. Though I think we can do it without what Dr. Blauhaus is virtually doubling the federal budget, a federal budget that I'm not paying for today, that I'm borrowing from others. What I love about Ms. Jayapal is she doesn't hide from those numbers that you've laid out. She recognizes it's going to be a tremendous increase in tax burden for the country. You can't get to $40 trillion without that, and believes it's worth it.